Hepatitis B is a double-stranded DNA virus, but the positive strand is incomplete. This is unique. Hepatitis B replicates using reverse transcriptase, meaning although it's a DNA virus, it can behave more like a retrovirus. The infectious form of the virus is called the Dane particle, and the outer envelope contains surface antigen, hepatitis B surface antigen, HBsAg, which circulates in very high concentrations in the bloodstream. That's why we can detect this HBsAg long before symptoms appear. There are multiple genotypes, with A and C being the most common in the US. And understanding these components are HBsAg, HBcAg, and HBeAg helps us to interpret serology. So this slide is showing us a relative viral concentration in different bodily fluids. Blood and semen have the highest viral load, followed by semen and vaginal fluids. Saliva contains detectable but lower levels, while urine, sweat, tears typically do not contain enough virus um, to transmit infection. This helps us counsel patients. Hepatitis B virus is far more infectious than HIV because of the extremely high viral concentration in blood and semen. This is just showing a geographic distribution of chronic hepatitis B infection. And again, it's just showing where prevalence is elevated. But it does not mean just because you're in a green zone that hepatitis B is not being spread. Here you can see the structural components, the outer envelope with hepatitis B surface antigen, and the nucleocapsid core that contains hepatitis B C antigen and hepatitis B E antigen. So remember, when you're looking at these kind of markers, we test for a hepatitis B surface antigen, HBsAg, which means a current infection. If there's HBeAg, this means an active viral replication and high infectivity period. And these are markers that we track in serologic diagnosis. For hepatitis B, the incubation period is pretty long, 60 to 90 days on average, and the likelihood of developing jaundice will increase with age, as we saw before with hepatitis A. Young children typically are asymptomatic, whereas adults are more likely to show clear signs of hepatitis. And chronic risk or chronic infection risk, though, is in reverse. So infants and young children are at the highest risk for developing chronicity for hepatitis B and at higher risk for becoming chronic carriers. Adults typically will clear the virus on their own. And this is why we have a vaccination that occurs for hepatitis B so young. Long-term complications for hepatitis B include cirrhosis and a high risk for hepatocellular carcinoma. So it's really concerning if hepatitis B does become chronic, especially in younger aged kiddos. Just like we saw with hepatitis A, this is a graph that demonstrates the order in which these serologic markers appear. So we can see this is time from exposure. So hepatitis B surface antigen is the first to rise. That means an active infection. So if this is present, active infection is taking place. We'll then see our IgM anti-HBC that will occur. This will occur soon after symptoms begin and can confirm an acute infection. Later on, we would see our HBeAg that can rise. We can kind of see this up here. This can indicate high viral replication and then high levels of infectiousness. And then during recovery, we'll see anti-HBs appears. Once we have anti-HBs appears, this signals immunity. And one high yield point, there is this window period where our surface antigen hasn't disappeared, or has disappeared, sorry, and our anti-HBs hasn't appeared yet. And during this period, kind of this zone here, IgM anti-HBC, which we can see here, is really the only thing, the only diagnostic marker of acute infection. So that can be really challenging. So this is like this point from here to this point here. When we look at, so that was acute versus when we look at progression to chronic, and chronic infection, our hepatitis B surface antigen will persist beyond 6 months. And that's part of our marker of chronicity. Our IgM anti-HBC transitions to IgG anti-HBC. So we can see this transitions to this. and that will persist for life as well. Our HBeAg may stay positive if viral replication continues, or you might see anti-HBe that will appear if replication slows. But even if anti-HBe appears, the patient may still be infectious. So the key point for chronic infection is our hemoglobin surface antigen is positive for 6 months or more. So if positive for greater than 6 months, greater than or equal to. That would be like our kicker for chronicity. So, with all these alphabet soup acronyms, we don't use a single test for hepatitis B diagnosis. We rely on a panel of serologic markers because our our hepatitis B surface antigen, HBsAg, tells us that infection is present. So, that's what that tells us. Versus our anti-hepatitis B surface antibody, or our anti-HBs, would indicate that we have immunity. This could either be from recovery or this could be potentially due to vaccination. So we have immunity of some kind. So either recovery or from a vaccine. Versus IgM, anti-HBC, confirms a pass or confirms an acute infection. So it's acute. Versus IgG, anti-HBC is either indicating a past or a chronic infection. Our HBe antigen indicates active replication and then highly infectious. And HBV DNA, which we haven't talked about yet, HBV DNA is the gold standard for viral load and then treatment response. And so we use all of these to guide both diagnosis and management decisions. So it's important for us to be able to kind of understand how to interpret all of these results. So if we get a hemoglobin or a hepatitis B surface antigen that's negative, and you see that the total anti-HBC is negative, or there's no IgM and there's no anti-HBs, this person's never been infected. Versus if all three of these are negative, but our anti-hepatitis B surface antigen shows that we have an antibody to the surface antigen, that's the patient being vaccinated. So both of these people have either never been infected by the active infection, but we have a vaccine immunity here. So this is never infected versus vaccine immunity. Okay. So then if we go to, oops, let me change this. If we see the hemoglobin or the hepatitis B surface antigen being positive and all the rest of these are negative, this means we have an acute infection or this could occur right after vaccination. The difference is then we'd see this after vaccine recovery. So this could be early acute versus once we see all three of these become positive, this indicates an actual acute infection. Once the surface antigen is negative, but these two are still positive, this says our infection's resolving. When we have this being negative, but we have these two that are positive, this means we've recovered from a past infection and we are immune now. So this we both have for our immunity people, we both have these, but the difference is if someone's recovered from an acute infection, they would also have total anti-HBC versus our vaccinated folks do not. And then lastly, our chronic infection folks, we will see that these two first ones will be positive. And then the kicker is we're looking for that greater than or equal to 6 months. So you have to utilize a table like this to interpret these results. You cannot just interpret them in a vacuum. It's important to recognize that only about 3 to 5% of adults who get an acute hepatitis B infection will progress to chronicity. So if you, let's say, were not vaccinated for hepatitis B, you got exposed to hepatitis B as an adult, and let's say that there was 100 of you that did, only up to 5 would actually progress to chronic infection. So it'd be 5 out of those 100 people would progress to chronicity. Everyone else, 95% of people, or 95 people out of that 100 adults exposed to hepatitis B infection who've never been vaccinated, they would all just clear the virus. But we flip that in kiddos. If an infant was exposed to hepatitis B infection and they weren't vaccinated, 95 out of 100 infants, 95% of infants that are exposed to hepatitis B would progress to chronic hepatitis B infection. Now you could say, well, how are they going to get exposed? I mean, it's true. Their chance of exposure is less than an adult, but it's not nothing. And the percentage of movement from acute to chronic is so high that that is why hepatitis B vaccination occurs, and that's why it occurs so soon in an infant's course of life. Because people who progress to chronic HBV, hepatitis B infection, and progress to chronic hepatitis 12 to 25% of people within 5 years will progress to cirrhosis. And then from there, people who have cirrhosis, 6 to 15% of those folks in 5 years will progress to hepatocellular carcinoma. And 20 to 23% of those people in 5 years will present or will move to liver failure. So let's think about our 95 kiddos that moved from acute to chronic hepatitis B infection. So up to a quarter of those kids or infants who have progressed by the time they're 5 years old, we'll do the quick math, 95% times 20 or 95 times 20.25 gives us, we'll just round up, it's 23.75. We'll round up, so 24 of these 95, by the time they're 5 years old, would, in theory, already have liver cirrhosis. And then of those, okay, a quarter of them, by the time they're 10, we could say, so what is 24 times 0.23, six of those by the time they're 10 years old would have liver failure, right? And on this side of those 24 kiddos, 24 times 0.15, four would have cancer by the time they're 10 years old, right? So this is why vaccines exist. It's to prevent these bad outcomes from occurring. And so that's why if people ask or you're thinking about, well, why is this offered so early when, it's very rare that an infant would be potentially exposed to hepatitis B. I mean, obviously being in a hospital increases risk, but still very rare outside of vertical transmission. It's because of these outcomes. We're really trying to prevent these chronic permanent outcomes for a liver transplant, which is hard to get in general, especially for a kiddo, or even worse, death. No one wants to be responsible for giving an infant, no physician wants to be responsible for giving an infant a death sentence. So it does not mean that you can't have those conversations with your patients about, benefits and drawbacks for vaccines. But this data is why it is so concerning for us to just have this information and knowledge and not offer this treatment for folks. It's still important for adults, but of course, these numbers are much less, right? 5 out of 100. So then, of those 5 people, one in four, or one or two of them will progress to cirrhosis, and then maybe one of them to cancer and liver failure. Still, I mean, if you've gotten here, it's a high probability that some complications going to happen, but less numbers than in our infant group. Okay. So, what is concerning about hepatitis B infection, or what do we have to kind of keep in mind? Um, Hepatitis B infection is not just a hepatitis virus; it is oncogenic. More than 200 million people globally are chronic carriers, and chronic inflammation plus viral genome integration does increase the risk for hepatocellular carcinoma, even if cirrhosis does not occur. So, this is why we do have vaccinations and early treatment. So again, who gets chronic disease? The age and infection determines chronicity. Newborns, 95% of those exposed would develop chronic infection. Infants or up to 6 years old, only about 30% would progress to chronic infection, and adults only about 3 to 5%. It's also important to note that many infants are asymptomatic, even though they almost always become chronic carriers. And this epidemiologic pattern emphasizes why a universal vaccination at birth is a successful preventative measure. Perinatal transmission is one of the most significant routes by which hepatitis B virus becomes chronic. Because if a mother is positive for surface antigen and hepatitis B antigen, 70 to 90% of infants will become infected. 90% of those infants will develop chronic infection. So if the mother is hepatitis B surface antigen positive but HBe antigen negative, the infection rate drops to about 20%. But again, 90% of infected infants will become chronic carriers, which is why we screen pregnant patients for hepatitis B and we provide post-exposure prophylaxis at birth. Our prevention strategy has two components to prevent perinatal transmission and increase immunity in the general population. And universal infant vaccination has dramatically reduced new cases. Children and adolescents who are not vaccinated as infants should receive catch-up doses. And we also vaccinate adults at high risk, healthcare workers, people with multiple sexual partners, injection drug users, and individuals with chronic liver disease. And vaccination is the single most effective intervention to reduce hepatitis B virus related liver cancer worldwide. So it is a highly effective strategy. When we come back, we will look at hepatitis D virus.